Hi, everybody. Thank you for joining us today. Today's presentation is the relationship between adverse childhood experiences and mental health outcomes, presented by James Ruggiemora and Sarah Mendoza. Just as a reminder, if you guys have any questions, you can drop them in the chat throughout, and they're going to keep monitoring it while the presentation goes on. And if you want to receive a continuing education certificate for the credits for attending today's program, make sure to fill out the evaluation that's going to be sent to the email that you registered for the course with at the end of the session.
So thank you so much for that introduction. I will go ahead and share my screen. And while I'm doing that, Sarah, do you want to kick us off with introductions and then we'll go from there?
Sure. I'm Dr. Sarah Mendoza. I am an assistant faculty at Montana State University in Bozeman, Montana. I'm glad all of you could be here with us today. I graduated from the University of Central Florida and have been working with James for a few years in the clinic there.
Yeah. Thanks, Sarah. Hey, everybody. My name is James Ruggiemora, and I am a second-year doctoral student at the University of Central Florida. Also been working with Sarah for a couple of years now. And in this presentation, we'll talk about a research study that we've been working on for a couple months now. And feel free to engage in this presentation however you want. If you want to keep your cameras on, if you want to keep your cameras off, it's not a big deal to either Sarah or I. And also Sarah will be monitoring the chat. So if you also want to engage with questions or comments there, someone will be monitoring the chat. With that being said, today we'll be talking about adverse childhood experiences as predictors of treatment outcomes in a training clinic that we have at the University of Central Florida. I do want to preface our presentation by saying that we will be talking about adverse childhood experiences. And so I invite people to take care of themselves if something comes up that may feel harmful to them. We absolutely respect how you choose to take care of yourself during this presentation, but we will be talking about some weighty topics like suicide, substance use, and neglect. With that being said, let's get started. So, adverse childhood experiences. These are experiences that we'll talk more later in the presentation, but have significant challenges and outcomes, both in our society and on the individual level. The consequences of adverse childhood experiences can be seen in many ways, in many forms related to both physical health, mental health, and it affects how we go about our day-to-day business and day-to-day lives. Unfortunately, ACEs is a significant public health crisis in the United States, and it has contributed to a significant portion of death in our country. And it also doesn't seem like it's easing up anytime soon either. And the COVID-19 pandemic further exacerbated ACEs, which necessitates the need for more effective interventions in mitigating them. So in this presentation, we have three objectives for you all. To understand the prevalence of ACEs in a community counseling training facility, to evaluate the impact of ACEs on mental health symptoms before and after intervention, and to explore the role of counseling in mitigating the effects of ACEs. To give you a brief snapshot of our methodology, we're not going to get too in-depth about it because by training, Sarah and I are counselors and we want to keep it more practical to you all and to our audiences. So if you want a more detailed discussion about our statistics and all of that, please don't hesitate to let us know, but we'll keep it more practical for this presentation. But essentially, we had about 90 participants who attended our counseling clinic. The counseling clinic is part of our university training program at the University of Central Florida, where both master level and doctoral students take part in either practicum or internship experiences. And we take clients from all over the Orlando area via in-person and telehealth. And for this study specifically, we had two questionnaires that we looked at. The ACEs questionnaire, so we wanted to see what ACEs our clients presented with, and also the OQ45, which is an outcomes questionnaire that we use to monitor and track the progress of treatment for anyone who chooses the clinic as their mode of clinical care. Data analysis, we use regressions and correlations. Very simple. Correlation does not mean causation, so we're just looking at the relationships, and regressions to see the predictive nature of ACEs and clinical outcomes. And then Sarah will talk about our intervention.
So when you think about what do we offer in a community-based clinic that's meaningful for counselor educators, University of Central Florida is not the only school that has a clinic, and we're using Rogerian counseling methodologies. When it comes to the process of training future counselors, it's a generalist education and reflective practitioner modeling. So we're talking about client-centered therapy, where the client leads, they come in, there's a warming up process where you get to know and build rapport and hope to identify goals that the client is prepared to work on. And so a lot of that practicum training is about being present in the room and using reflective skills that we evaluate using the counselor competency scale revised. The CCSR was implemented first and validated at the University of Central Florida by Dean Lambie. So when you think about how these students were intervening with clients in a community clinic, you're thinking of a client-centered focus, and then they're being evaluated on those skills. And in order to be promoted from practicum to internship, we're looking for meeting expectation or higher. We're looking for them to use some of the skills. I took a snapshot, like reflective paraphrasing, reflection of feelings, advanced empathy skills, like tying a feeling to a meaning. So our students are on a live monitoring system, and they are supervised by licensed professionals. So it could be a core faculty member or an adjunct faculty member. And those professionals are able to see them in real time in the room. They also have earpieces. So the counseling student can have an earpiece in the ear where their professor talks to them in real time. And if it's telehealth, we can use chat. We can also connect to the room virtually that they're in if necessary, as well as physically going and knocking on the door if there are ever a serious need. But primarily the interventions in the clinic are with common outpatient mental health concerns and client-centered therapy. So we want to make sure we went over what were we offering when we looked at the clientele who come into UCF's community clinic.
Awesome. So to talk a little bit more about our measurements, the Adverse Childhood Experiences Scale, and it's a very simple scale that assesses the number of adverse events. Here in the picture on my right, maybe your left, are all of the types of adverse experiences that a client can check off. There's 10 of them. And the internal consistency of Cronbach alpha is 0.78, which is a strong Cronbach alpha. But I also want to acknowledge that there is also an addendum to the ACEs scale that includes 4 more adverse childhood experiences, but we don't use that in our clinic specifically. We use the original by Folletti and colleagues. The second measurement that we used was the outcomes questionnaire, or the OQ45, and it assesses baseline and progress of clients throughout their time in therapy. And it has 3 subscales: symptom distress, interpersonal relationships, and social role. And what's really important and significant about this questionnaire is the critical items. And we have 5 critical items that alert counselors to concerns of suicidal thoughts, conflict, and substance use. what we and how we train our counselors and master students is if a client were to check off one of these critical items, those are the things that we would need to address and prioritize in treatment. There's a total of 45 items, and the internal consistency for symptom distress is 0.88. Interpersonal relationships and social role is 0.90. So there is strong Cronbach alpha for these subscales. So what does that all mean? Well, when we surveyed our participants, this is the breakdown of the ACEs that they presented with. As you can see, there were a lot of ACEs present. And SWORAT put down by caregivers, that was a significant one at 48%, along with lived with someone who is mentally ill, 46%. And we displayed the frequency because we are showing that not only are we seeing ACEs prevalent in the entire United States in a variety of populations, but we also see it in the greater Orlando area within the clients that we see at the community clinic. So there is consistency in that, unfortunate consistency, but we do see a lot of ACEs through the clients that we see in our clinic. When it comes to findings, we found that ACEs did not significantly predict overall mental health severity before or after counseling, but they did predict critical item scores at both time 1 and time 2, indicating an impact on specific symptom domains. Our hierarchical regression showed that ACEs explained an additional 6% of the variance in critical item scores at time 2 after controlling for baseline functioning. And Sarah will talk about our implications.
When we think about what James just outlined, is that there's not a significant difference when it comes to the overall outcome of counseling. For me, that's hopeful in the sense of client-centered interventions that are focused on the well-being of client-led sessions, where we focus on what is meaningful to them and why they're presenting for counseling in the first place. It doesn't significantly change that course of treatment to have ACEs at a higher level or another when it comes to overall well-being. What stands out to me is the critical items are what popped off the page. And so I wanted to read a couple of the examples of critical items that we're referring to when I think about implications from the study. One is that you have suicidal thinking. Passively suicidal in any way is something that would come to the immediate supervisory needs of the student. And when we talk about conflict, there's item 44 on the scale. It says, I feel angry enough at work or at school to do something I might regret. And so the integration of awareness in our students and in our counselors in training about why a critical item would potentially jump off the page with someone who has a higher ACE score is that it's their nervous system. So when you think about how we're impacted by early childhood events that shows up in the counseling relationship or in our outcome measures, those things like stress management, visceral responses to conflict, or having what might be in the trauma world, a dorsal collapse into suicidal thinking or wanting to shut down, not exist, morbid thought patterns, those items did come up the page. And that would be something we want to train our students in, that we have to be uniquely empathic and understanding to how someone's early development prior to 18 would impact their ability to cope in these areas of conflict or find solutions when they're under extreme distress. So our suggestion here is that we consider adding trauma-informed care to every aspect of counselor education, so that throughout the program, we're looking at how skills apply or how case conceptualization applies in the context of ACE scores, because it is that prevalent. Another item here that I would bring up is item 2, and it's just, I tire quickly. It's important to remember that the ACE evaluation was created for physical health. The initial findings in the 1990s were around people's diabetes, heart disease, other physical health outcomes. And we've gone on to have many more years of research on ACE scores and seeing how they show up in mental health. But things like getting tired quickly can show up in terms of people's past traumas and how their body learned to manage stress. I think we can go to the next one. When it comes to supervision and treatment planning and thinking about how to manage clients that are directly focused on their overall well-being in an outpatient clinic, we think about the practices that we might help the client to understand themselves in the context of their responses to situations, whether it's providing psychoeducation or helping the student in training to relate to the client on the items in their life that they had no control over. So we don't want to blame our clients for what happened to them or around them. We want to give them adaptive functioning skills that meets their needs. And we work through these things by increasing coping skills, by increasing awareness, and then working through eventually, if the rapport is there and the client is ready, past traumas in their direct way of what happened and the storyline. So I think that in the idea of how to help students grow, we want to include in treatment planning, working that periphery to core reality. We don't want to go headfirst into trauma. We want to work on coping skills, make sure there's adequate support systems. We don't go right for the ACE material, so to speak. We want to give students a chance to really flex some of those reflective practitioner skills, build the rapport, and then as the client's ready, if the client's ready, work towards trauma and what else might be coming up in their day-to-day lives, preventing them from living the quality of life that they hope to.
So in terms of limitations and next steps, we recognize that this was a retrospective reporting. And so because of that, there may have been some underreporting of the ACEs in a community sample. Because when we distribute the survey of ACEs, that's at the beginning of treatment, but we don't give them again later in the treatment. And so when we give it at the beginning of treatment, we recognize that the therapeutic relationship may not be as strong as it would be midway or at the end of treatment. And so that can lead to underreporting of ACEs. Future research should explore the impact of ACEs on treatment outcomes over longer periods. Within our community clinic, we don't have a specific limit on how many sessions that clients can have. Usually, our students see anywhere between 8 and 10 sessions, or we have designated 8 to 10 sessions over the course of a semester. However, clients may only present or show to 4 or 5. At least in my experiences, that may fluctuate between years as well. And because of COVID, that has also hurt number of sessions that clients appear at. And then ACEs data collection, we could look at completing it later in therapy as the therapeutic relationship continues to enhance trust and accuracy. Sarah, would you like to add anything?
I think just the general thought that all of this is self-report is what comes up for me, not just on the ACE, but also the outcome questionnaire. And I think there's some social desirability to be improving in counseling. So we want people to get better, and they also want to get better. And that's another thing where the longer they're in treatment or the more rapport with the student counselor, the more we might have accuracy. And I think you've addressed that well enough.
Cool. So to conclude, unfortunately, ACEs are highly prevalent in the sample that we looked at and have a significant impact on the critical item scores in clients attending our training clinic. Counselors in training should receive appropriate education and supervision to address ACEs in their practice. And that can look like integrating more ACEs screening and trauma-informed approaches into counseling practice to improve treatments, but also through curriculum design as well, and integrating a more trauma-informed perspective and framework, not only during practicum courses and internship courses, but at the very beginning too, in those foundational courses like ethics and counseling skills. And those are our references. And now we want to open it up to anyone that might have questions. Just feel free to unmute and or place your question in the chat.
Okay, I like this question. So in the chat, I'm gonna turn this to me, sorry. I love the question. What if the client is never ready to discuss ACEs? How do you move forward in supporting them? I think this is a very fair comment, and we don't know how long it will take anyone to discuss ACEs, if ever. I think that cultural stigma persists. And this is why when I talk about supervision or training, we often work periphery to core. And we start with what interrupts your life now. Is entering a social situation setting off signals that you're unsafe? Are you not sleeping through the night? Are you finding yourself reacting to situations and circumstances? So we want to build as many coping skills and relate to that person where they're ready in their day-to-day life, even if we never work our way into discussing the thing, whatever the thing is. Growing up with a mentally ill parent, having an incarcerated parent, the unpredictability of a parent who uses substances, being physically abused as part of punishment, being sexually abused and never having shared about that. So I think that for me, a lot of it is around building in those immediate coping skills, having the client remember that they are an adult who can make choices and set boundaries. A lot of the times I've worked with women who have survived sexual trauma, and I always say it's really important to me that we build your toolbox for feeling safe as a woman in this world, because that reality isn't going to change, and you have choices you can make to help yourself. And you know what that looks like may be different for each person, but we're always about meeting people where they are, especially in that client-centered approach, which is why it is a foundational master's level training or doctoral support role, because no matter what field, what part of our field you work in, those are important skills to have to meet people where they are. James, anything you would add to that?
Yeah, I think for me, both as a clinician and a non-clinician, is to be prepared. And I know that whenever I go into a session, knowing that there's a very good chance or likelihood that the person that I'm sitting with, that I'm working with, will have some form of ACEs, helps me to better prepare and educate from a trauma-informed perspective, right? And that includes, like what Sarah mentioned, of building coping skills, right? We want to give them the skills that they can practice, which doesn't directly address the ACE, but when they do bring it up, they are already equipped to take care of themselves, to regulate themselves in those conversations. And who knows, they may never bring it up with you, but they may bring it up later in other therapy if they choose to continue it. But you know, you set them up for success by building in those coping skills, those strategies that you have continually practiced with them, and also built that relationship. Because it is a big deal for someone to come to therapy in of itself, yet alone to stay in therapy, to self-disclose all of the awful things that might have happened to them. But how lucky are we to give them a skill set that they can practice both in and out of therapy, regardless of whatever and however they present. All righty. Well, thank you so much for everyone for participating and for learning with us today as we shared our research with you all. If you have any further questions or want to incorporate the OQ or CCSR in your institutions or with your students, please let us know, and we'd be happy to connect you with the appropriate resources and people.
Thanks for joining us, everybody, today. Make sure to fill out the evaluation in your email. You should get that by the end of the day today. If you have any questions, you can always email the Office of Continuing Education as well. Enjoy the rest of your day, everybody.
Thank you, everyone.
Thank you.